From the JAMA Network, this is JAMA Internal Medicine Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Internal Medicine.
Hello and welcome to our listeners around the world. This is Dr. Eve Rittenberg, and you're listening to JAMA Internal Medicine Author Interviews. Thanks for joining us. Today, we're delving into how to treat menopausal vasomotor symptoms, so hot flashes and night sweats. This is a clinical topic that affects a huge number of people. In fact, more than 3/4 of women report vasomotor symptoms during perimenopause or menopause. And speaking personally, they can be really disruptive. Although hormone therapy is the most effective treatment for vasomotor symptoms, there are many women who either have contraindications to hormone therapy or who prefer to avoid it. So as clinicians, women often ask us what other options they should try. Are there non-hormonal medications, supplements, or behavioral strategies that might actually help? And what should they expect from those treatments? So happily today, we have experts in the field to give us some guidance. I'll be talking with two of the authors of a clinical review of non-hormonal treatment of menopausal vasomotor symptoms that was published recently in JAMA Internal Medicine. Dr. Alison Huang is a professor of medicine and the director of research in the Division of General Internal Medicine at the University of California, San Francisco, and she's the incoming editor of the JAMA Plus Clinical Trials channel. Welcome, Dr. Huang.
Thank you. Delighted to be with you.
And Dr. Stephanie Faubion is chair of the Department of Medicine at the Mayo Clinic in Jacksonville, director of the Mayo Clinic Center for Women's Health, and medical director of the Menopause Society. Welcome, Dr. Faubion.
Thanks so much.
So let's start with Dr. Huang. Could you give us a brief overview of what the non-hormonal options are to treat vasomotor symptoms of menopause?
Thank you. So at the moment, there are two kinds of FDA-approved non-hormonal medications for vasomotor symptoms. And then there are a variety of other medications and non-pharmacologic treatment options that are used based on evidence from trials, but without FDA approval or regulation. I'll start with the FDA-approved treatments. So the one that has been around the longest is a selective serotonin reuptake inhibitor medication, paroxetine, approved in a specific lower dose, specifically for treatment of menopausal vasomotor symptoms. And then new, just in the past 2 years, is fezolinetant, a neurokinin receptor antagonist that has more recently provided important evidence of an important mechanism underlying the etiology of hot flashes and is now the second FDA-approved treatment option with efficacy from controlled trials.
So maybe before you move on to the other options, I'll jump in here and just ask, Stephanie, maybe you can tell us a little bit about the pros and cons. Like, when would you choose one of those two options to treat a woman with vasomotor symptoms?
Well, I think we probably better talk about the other options too, because I choose so many other options before I choose these. So, yeah, I can say honestly, I don't typically use the antidepressants. I rarely use the antidepressants, put it that way.
And why is that?
Because they're not that effective. They reduce hot flashes by maybe 40 to 50%. When you're talking about a sugar pill reduces it by about 30%. So there's really not just a lot of benefit over placebo. And unless a woman really has focused mood type symptoms like depression or anxiety, where I might get a dual benefit from an antidepressant, it's really not my go-to.
And how about fezolinetant? Is that something that you do tend to reach for early on, or?
You know, the main barrier to fezolinetant is I have yet to get it in someone's hands because of insurance coverage issues. And so there are a lot of barriers, including in some of the patients that I see on a regular basis. They have to go through 2 other non-hormonal agents before we get to that one. And ironically, that means they have to go through non-FDA approved options before we actually get to the FDA approved option, which seems a little backwards in my view. But at the same time, I think we'll get there. I think it's going to take some time. With time, the cost of the drug will come down. And as we have competition in that area, I think it will come down as well.
Thank you for that real world insight into whether or not it's even possible to get these for patients. So you mentioned that there might be other treatments you would reach for first, even in the non-FDA approved kind of bucket. What are those?
So I found a really nice option for those patients who just need it short term. So, for example, a survivor of breast cancer who is having really significant symptoms and we just need to get her over the hump. I actually use oxybutynin. I typically start it at a dose of 2.5 milligrams twice a day and then go to 5 milligrams twice a day. And that is pretty effective in reducing the hot flashes. And there's not so much of a concern about long-term risk of dementia if we're using it short-term.
Great. And how about you, Alison?
First, what Stephanie's just said is sort of brings up multiple issues and challenges in selecting the right treatment approach for patients. I mean, one challenge is where we're most cautious about hormonal treatment, and then at the same time have to be concerned about side effects of non-hormonal treatments is in older postmenopausal women. In addition to conducting research in the menopause space, I conduct research in bladder and urinary problems. I mean, oxybutynin is a medication for a long time prescribed for overactive bladder and urgency continence, and yet we have increasing concern in the older postmenopausal women about side effects.
And as we've learned, symptoms often persist for a long time, right? So
That's right. I mean, it's really almost nothing do we worry about that much what will happen to the woman if she tries it in the short term. It's
Mhm.
really the woman with the frustrating, persistent, stubborn symptoms that go on for a long time and for which she's thinking about treatment for years where we start to be concerned. So in some ways, one realization from reviewing the evidence with Stephanie for this clinical insights review was that we have potential concerns about long-term health risks for hormonal treatments for menopausal vasomotor symptoms, but we have limited data about really long-term safety for non-hormonal treatments. And think
Mhm.
about the options that we do bring up in this clinical insights article: oxybutynin, SSRIs,
Gabapentin.
gabapentin, right? These are things where questions are brought up about the potential downsides with prolonged use across the aging spectrum as women transition from midlife to older age.
But at the same time, we're also learning more about the ramifications of untreated vasomotor symptoms, right? And their impact on quality of life and productivity at work and sleep and mood. And so it's a tricky balance to walk.
For sure. And one thing is the recognition that so many women are affected by these symptoms.
One thing that was interesting to me when I read your clinical insights, and maybe this is just my not knowing about it, was your discussion of the behavioral non-medication treatment options and that there's some evidence that these might be effective as well. So is that somewhere that you go to when you're particularly concerned about side effects or someone wants to avoid medications altogether?
I think cognitive behavioral therapy is something that we probably don't use enough. It's obviously not going to stop a hot flash from being triggered, but it does help you alter your response to the hot flash such that it's not as bothersome. So I think that's something that we could use more. There are some barriers to the use of cognitive behavioral therapy, and that is that not everybody can get to a therapist. We are starting to try to get around some of those limitations by creating modules online. There are some workbooks that women can do. My team is currently investigating the use of virtual reality and delivering cognitive behavioral therapy for hot flashes through VR, which would increase access to this modality. So I think we have some things like that. Hypnosis has also been shown to have some benefit. And again, you have the same issues with administration. Somebody has to give you hypnosis, but in the trial that happened a few years ago, Deb Barton's group tried it and actually recorded the session and handed it to the patient on I forget if it was a DVD at the time or what kind of recording form was available then. But so the patient could actually self-administer the treatment later on. But again, there are these inherent barriers to some of these behavioral therapies that hopefully we can get around with things like VR. Hypnosis can be delivered through virtual reality as well.
Are those as effective as some of these medications or?
Let's be real here. Most of these medications aren't that effective for hot flashes. So I think, yes, they can definitely make it to where these symptoms go from really bothersome, getting in the way of quality of life, to making them much more tolerable and kind of background noise. But will they make them go away altogether? No, really none of these therapies will make hot flashes go away altogether.
One challenge in making comparisons between different kinds of treatments is that There haven't been many head-to-head trials, right, that are directly comparing different types of treatments and in the same population or same participants recruited from the same areas. So we can only really extrapolate by looking at reductions in symptoms reported in one trial conducted by one group, for one treatment versus another trial conducted by a different group with a different treatment. From that, the reports of improvement in symptoms with cognitive or behavioral therapies, the magnitude can be pretty impressive. The magnitude can look like, in many cases, surpass what's seen right from medication trials. That said, it is a little harder in behavioral therapy trials to blind participants, to blind researchers performing the studies. A little more challenging to control for that placebo effect that we referred to earlier. So I think this is an area probably where we need more work. The other thing I just want to mention on this topic of behavioral treatments is that this is a podcast for JAMA Internal Medicine. Both Stephanie and I are internal medicine doctors. Perhaps a lot of folks listening are internists. As internists, we're not great at delivering behavioral treatments. Right? We don't know how to deliver them very well ourselves. We're often not that good at referring for them. Internists in general have always been more comfortable prescribing. That's what we do. And that's probably for this condition, this problem, like so many others, we really underutilize behavioral treatments because we don't feel as comfortable and we don't know how to implement them in everyday practice settings.
That makes sense. All right. So I want to move on to the last big bucket of treatments, which is over the years, many, many patients have come to me asking about supplemental and herbal therapies and often very attached to them. And I wonder if you could talk a little bit about the evidence sort of about those complementary treatments.
Gosh, I wish we had just a whole lot of stuff to tell you about the success of herbal treatments, but unfortunately, there is really no data to support the use of any over-the-counter supplements or herbal treatments. And, when I talk about this, I said, you want to know what supplements work? And then I just have a big silence. And so, unfortunately, that's what we have. And I wish it were that easy to tell women, it's just an over-the-counter supplement. It's so easy, it's safe and effective, and it works. A lot of the data is just the absence of data, but of the data that we do have, we haven't found these therapies to be effective. So we have two issues. We have a lack of data, but we also have, in some cases, data that shows no real effect. And I think we have to talk about here how these things are being talked about on social media. And you really have to be careful who your source is because they may be selling them. And so it's hard for women out there to really understand what the data show because you might have somebody pointing in the background to some study that says, oh, it improved hot flashes by 50%. But you look a little closer and it was an uncontrolled study with 20 patients in it. So there's a lot of misinformation in this space, and the area of supplements is one of those areas. There's a nonprofit called Truth in Advertising that just went after the supplement industry in this space and sent over 100 cease and desist letters for companies that were making what they felt to be false claims around menopause treatments.
That's such an important point. People come in having seen so much on social media, and it's very hard to sift through some of that. Where do you direct people to get evidence-based recommendations, either patients who come to you or even clinicians?
Well, I will start with menopause.org, which is the Menopause Society, and we do put out position statements where we review the data on non-hormonal and hormonal medications. This is an ever-evolving field. Fortunately, I think there is a little more interest in really creating evidence around these treatments, and that's a good thing. But there's still a lot of noise and misinformation out there. So I would encourage women to be savvy consumers and make sure that they understand the source of the data that they're looking at for these products. Alison, I'm sure you have more to add.
What's a challenge here also is that I do think that a conversation with a healthcare provider is important because part of it is sort of setting the right stage for how to think about treatment. What are the treatment goals? What kind of degree of improvement in symptoms would be worthwhile? What's going to be the burdens, both in terms of cost, sometimes for paying out of pocket, or the burden of using a treatment regularly, and what are the side effects? It's the kind of thing where it is hard to say, just look at this website, even if it's a great website, right?
100%.
Something we're really saying, what's the symptom that's bothering you the most? Would an X% relief in your symptoms be worth it for you to take a pill every day, to pay out of pocket, to spend time, for example, in hypnosis or CBT sessions, and recognizing that basically every treatment in the world, including non-hormonal treatments for menopausal symptoms, they could offer some benefits. They may have some side effects. They may have some potential for longer-term health risks. And do you feel like you could tolerate that possibility to try it out for your symptom benefit? So it is an interactive conversation upfront rather than just about provision of information, right, about treatments that exist.
100% agree.
I wish we could have a whole other episode just to go into that conversation and your advice, because I found myself wanting to know more about your approach.
One reason why, of course, many women with vasomotor symptoms go without treatment is because they're not even being asked about their symptoms. They're not being offered treatment. But one is that, it's reasonable for women also to think about the benefit burden trade-off and decide that they want to wait or they want to consider different approaches.
I think we have to understand that most medical providers, internists, family medicine doctors, and OBGYNs have never been educated in menopause management. It's really important not to take just there's nothing that can be done from your clinician if you really are having bothersome symptoms, because many women are told that, or that their symptoms don't warrant treatment. And so if you feel like you're not getting the answers that you want, you should make sure that you seek out someone who has knowledge about menopause management, because the answer should never be that we can't do anything for you.
That is such an important message to end on. Thank you both so very much for joining me today. I'm Dr. Eve Rittenberg. I've been speaking with Dr. Alison Huang and Dr. Stephanie Faubion about non-hormonal treatments for menopausal vasomotor symptoms. You can find a link to the articles we discussed in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.